So each year for our AOA induction day, we invite a visiting professor to spend an entire day with the AOA students. So while in general our visiting professor is someone who is nationally recognized as a leader in teaching, service, research, and/or patient care, most importantly he or she serves as an exceptional role model to the students. And this year we were very honored to have Dr. Karen DeSalvo join us as our 2013 AOA visiting professor. Since 2011, Dr. DeSalvo has served as the City of New Orleans Health Commissioner and the Senior Health Policy Advisor to Mayor Mitch Landrieu. Under her leadership, the New Orleans Health Department has developed effective and innovative strategies to improve public health, including promoting partnerships and collaboration between government, community, and the private sector, and focusing on evidence-based policy and programmatic actions that address the social determinants of health. Dr. DeSalvo's career work has focused on improving access to quality, affordable community health care for all. She's been an active leader in health sector recovery and reform efforts in Louisiana since Hurricane Katrina, and is a sought-after expert of healthcare delivery reform. Following Hurricane Katrina, she envisioned and led the effort to create the nationally recognized model of neighborhood-based medical homes for low-income, uninsured, and other vulnerable populations in the New Orleans area. This network has been hailed as a national model and recognized by the National Committee for Quality Assurance. Dr. DeSalvo also has led the reestablishment of a hospital-based health system after Hurricane Katrina. Prior to joining the mayor's administration, Dr. DeSalvo was professor of medicine and vice dean for community affairs and health policy at the Tulane University School of Medicine. She has served on numerous local and national professional boards, including serving as president of the Louisiana Health Care Quality Forum and the National Association of Chiefs of General Internal Medicine. She earned the distinct recognition of Women of Excellence in Healthcare by the Louisiana Legislative Women's Caucus, and outstanding alumni for Suffolk University. She's the founder and current president of 504 HealthNet, a consortium of safety net providers in the New Orleans region. She received her medical doctorate and master's in public health at Tulane, a master's in clinical epidemiology from the Harvard School of Public Health, and her BA from Suffolk University. She was also awarded an honorary doctorate from Suffolk University in 2010. So with that, I'd like to thank Dr. DeSalvo for being here and welcome her.
Thank you, Carrie, and thank you to the students for inviting me. It's been a fun almost day since I got here last evening. I had a chance to have dinner with you all and then breakfast with you all. I'm looking forward to lunch and then dinner again, maybe. I don't know, a lot of great experiences. But I just want to truly say that I've been incredibly impressed with the kinds of students that I've met in this experience, and you all should be quite proud of what you have become already, and look forward to seeing how your careers progress. I wanted to share with you all today a story about New Orleans Rebirth. We spent some time this morning talking about our near-death experience in New Orleans, but it is really a positive story, and I want to talk with you about how we are working to improve the public's health and some reflections about ways that what we have learned might be helpful in other communities. We have a reputation earned as having both poor health and health care, and it is partially because of what we created systematically and from a policy standpoint to have a system that was very dominated centrally centrally financially and geographically with a public hospital. We took the opportunity from Katrina to build community health as a front line of defense, and then worked to make sure that there was proper technology to support care of the patients and the information that we could learn about where we were going in the future. I'm in a role now of trying to transform the health department and then be able to focus as a city on the social determinants of health, which is really where the money is. My world changed, as did the world of millions of others, on August 29th, 2005. It was a devastating experience for the nation, and certainly the Gulf Coast, in which a storm called Hurricane Katrina grew into massive size and decided she was going to go straight for the city of New Orleans in a worst-case scenario, which I'll tell you, we thought worst-case scenario in New Orleans was that a storm would come essentially up the river, overtop the levees, and the city would flood, and we would turn off the lights and move away. Actually, what happened was that the flood wall system broke in our city. The storm did not even come hit us. She destroyed the Gulf Coast of Mississippi. And really what happened to us was storm surge overwhelmed the insufficient engineering by the Army Corps of Engineers, which they have acknowledged. And in a series of domino effects, the flood walls broke and the city began to flood. 80% of the landmass of New Orleans flooded, which is equivalent to an area the size of the island of Manhattan. It was underwater for as much as 30 days in some areas, and created a situation where even if the water had receded, there was so much damage to the basic infrastructure of many facilities that it was necessary to rebuild. That meant 200,000 houses. That meant, for example, a parish south of us, every single building or house was flooded or destroyed in some way in St. Bernard Parish. So quite a huge amount of devastation. Now, for those of y'all who have been to New Orleans, you probably only been to this part of New Orleans in the French Quarter. The rest of the city, including, for example, New Orleans East, is where I'm doing quite a bit of work. This whole area of the city, 80,000 people live there, and we still don't have a hospital or emergency room for them. But what you will notice is that the city's built like a bowl, Mississippi River, right, surrounded by water everywhere. And that if you were on high ground here along the river, which we didn't know was high ground, but now we sure do, the city came back pretty quickly, including the Central Business District and the French Quarter. But right here on the edge is where our medical facilities were concentrated, and so they did all flood, though not quite as significantly as this deep water that we had in the northern part of the city. And so with that flooding you saw on television and subsequently have seen quite a lot of reports, our safety net infrastructure was crippled. And for us, that meant essentially the public hospital. This was a giant, beautiful facility built in the 1930s that was responsible for the majority of all the training of physicians from LSU and Tulane, as well as pharmacy students, nursing students, social work students. It was a place where you could, in this nation, still go and see really interesting disease afflicting people that unfortunately was entirely preventable, but not caught because we just decided from a policy standpoint that we were going to not fund upstream and support primary care and prevention. I used the example of syphilis this morning with the students. I saw a lot of tertiary syphilis in my time there, including as a resident in the early 90s. And it's really just hard to imagine that could happen in the United States of America, much less the kinds of other cancers and advanced congenital heart disease that we saw. So a really interesting place to train, but also because of the way we were paying for care, we had a lot of uninsured and they were dependent upon that system. I spent a portion of my career running clinics and quality committees and medical records and other things in that building. It was a place that I did my National Health Service Corps training. I had a clinic there for 7 years. I knew it really well, and I knew the patients really well. And I also had the experience of trying to care for people in a system that was really pretty hospital-focused and didn't have infrastructure for follow-up. I'll give you an example, not when I ran the clinic, but later. At the time of Katrina, if you missed your appointment in clinic because the bus was late or because your child was sick or your parent was sick and you had to stay home with them or you couldn't get off work, even if you were an established patient in the resident continuity clinic, which was pretty much the only medicine clinic, it was 12 months to get a new appointment. That's if you were an established patient. So you would do what any rational person did. You would go to the emergency room to get your medications refilled or try to call somebody. And it was a really frustrating and challenging system, but a lot of patients had learned to work it through, and it was just what we kind of knew. Now, in the background, it wasn't what we all wanted to have, and some of us, we wanted to see some change, but the big building cost a lot of money to run, and there was a way to fund it through disproportionate share, and the schools of medicine for Tulane and LSU had a lot of teaching dollars predicated on it, including the residency salaries and fellow salaries. So when we lost that hospital, and we were not allowed to go back in, and everything else was shut down, Tulane Hospital, University Hospital, the VA Hospital, there were still people who needed care. Now, though we did evacuate 90% of the region around New Orleans, there were still tens of thousands of people who remained behind, and they were the sickest of the sick and the poorest of the poor, and there were first responders who came in who also needed attention. There was a series of efforts to kind of stand up services that is an entire talk in and of itself, but for purposes of this crowd, I want to make sure that I talk about the seeds that were planted by our MedPeds residents at Tulane that created really an opportunity for us to think differently about how we delivered care and how we taught medicine. These first aid stations that they set up and then called us in to help staff and move forward on really became what is now a robust primary care network I'll tell you about. What happened to us on these streets was that we were delivering first aid, but it was really a lot of psychological first aid. It was a lot of true public health. How's the water? Do I need a tetanus shot? Very multidisciplinary effort because we had volunteers from the mental health sector and nursing sector. But what I saw as a teacher and as an administrator was a very palpable shift in the way that my faculty and our residents approached patients. They were able to contextualize their health because it was clear and obvious that this person in front of you was homeless and without a social network and jobless, and their child didn't have a school, and they had a lot of public safety and mental health concerns. A lot of the residents and faculty had the same issues, right? So everybody was experiencing this shared grief and concern about the future. So there was an opportunity for that bonding. But when you're seeing somebody in open air like that, and you can see the devastation all around, it really just changes the way you think about where people live, learn, work, and play, because it's all gone, and how that affects their health. So specifically, I need my insulin refilled. Great, I can do that. I can be all perfect at the right time for your care of your diabetes. But if you don't have a house or if you don't have electricity at your house, it's kind of a moot point, right? And what we know from disasters like this and from the regular world is that housing, for example, is the most important predictor for good health outcomes. So in all of that, when we had the opportunity to move the residents and the resident clinics back into a building, we still chose to leave that out on not on the street, but in the community. So this was an opportunity for us because Jeff Weiss, our program director at the time, who's now our DOI for the university or the med school, said October 1, we're going live with training. We did in this place and others, resident clinic, continuity clinic on the street, out in open air, and it worked because it's really about the teaching and it's about the shared experience and the learning, and somehow we got through. But in addition to changing the way that we taught and where we taught and what we taught about, it was also from a big picture view an opportunity from the tragedy. Now, I don't want to be trite about it. 1,800 people died from Katrina. I told you about some of the devastation of our infrastructure. But the resiliency that the people of New Orleans tapped into to decide that they were going to come back off their knees and that they were going to not just come back, but come back better is a remarkable story in and of itself, and it happened not just in healthcare, but in other areas. This was a very deliberate decision. There was an intense amount of planning that happened over the course of a couple of years, through a series of statewide and local efforts, a lot of community input and organization, a blueprint written about where we would go when. But it was also mirrored by concurrent work on the street that allowed us to point to prototypes that we built that were medical homes, not just on paper, but actually seeing patients as we move forward, new ways to train, new ways to do mental health integrated in the system. And I'll be honest, there was a couple of days where I thought we were going to be worse than we had been before. And I think we came close a few times, but we're definitely better, and I'm going to share a little bit of that with you. Why would we want to be better? Well, we would want to be better because we have the reputation in just about any place you could find at the time, and haven't quite gotten over all of it yet, whether it's Commonwealth Fund or Kaiser's data or Dartmouth's data. Pick anyone, America's Health Rankings. We have the highest cost in the country with the worst quality. We have worst health status, 49th or 50th continuously in America's Health Rankings. So that includes not just health care, but behaviors and mortality, access to care, insurance coverage. We had some of the lowest density of primary care physicians per capita in the country. We had 23% of our community living in poverty. About 40% of children are born into poverty. 20% of our population was uninsured. If you are 19 to 64 age group, it's really more closer to 37-40% of the population uninsured. We had very strict rules about coverage in Louisiana and continue to this day. You have to make less than about $2,800 a year and have a child in order to be eligible for Medicaid in Louisiana. Childless adults are still ineligible for Medicaid. Very dependent upon then disproportionate share money to fund the public hospital, which just meant we didn't really build a system outside of the public hospital for the care of the some 250,000 that relied upon that for services. It was really driving people towards that geographically and financially centralized system that was what everyone knew. I'll tell you, it was also what we learned, not resilient at all for disaster every day. When you lose your building and the funding has to stop and then you get relocated to another part of Louisiana or Mississippi and you don't have an insurance card, you're out of luck. For a little while, everybody helps. There's a lot of volunteer clinics. But if you have to stay away for a year or two, it gets to be harder and harder, especially if you stayed away in Louisiana, to access services when the philanthropic and volunteer stuff started to wane off. It wasn't resilient in other ways, and I want to just mention that in particular from an IT standpoint, I want to share a bit about how we've been trying to improve that also, because we lost people, and that was, as a physician, a terrible feeling to not know. We had no relational databases, with some exceptions, like VA, for example, to know who was on Coumadin, who was on chemotherapy, where might they have gone, what was their regimen. We had HIV patients showing up at our street clinics asking to get help because they were out of their meds, TB patients who were on directly observed therapy in the public health clinics that were closed, showing up saying, I'm out of drugs, I need some help, and no way to figure out what they were on because all those paper records were flooded. They had been stored in various places around the city. So really strong message about the power of electronic health records for us. I'll say first things first, because this really is largely what happened, though before I get too far into it, I should mention, who knows who Tom Farley is? I know none of the students do, except the ones I had dinner with last night. You can raise your hands now. So Tom Farley is the Commissioner of Health for New York City. And Tom was in New Orleans at the time of Katrina. Tom tried to get us to think about the social determinants of health in our rebuilding. He tried to get CMS, Medicare, to consider that as a way to change the way they paid for services, and they literally laughed him out of the room and said, we are not going to deal with that. We're going to talk about rebuilding hospital beds and making sure there are fewer. We want to change the public hospital system. You know, it was a really different conversation. But so I say community health was the first place we went, but really Tom tried to get us to go to social determinants, but the community was just not ready at all. But there were a lot of us ready to think about, in the vacuum, with charity closed, with nobody having a place to go, and lots of these little seeds planted around the community, what if we turned those into neighborhood-based clinics? Because heretofore we'd had none in the city of New Orleans. One. I think for us in the city and for many people in academic medical centers, often medical students, this slide is one that was one of our powerful calls to action. We have spent, and we continue to spend, a lot of energy talking about this little box right here. When you're talking about 1,000 people in a community, really only one has to come to an academic medical center, Charity Hospital. Charity Hospital did a little bit of broader services. I mentioned emergency department visit for the uninsured, et cetera. There were hundreds of people that we were just basically ignoring until they got so sick that they had to come all the way to the academic medical center. We still spend a lot of energy in Louisiana talking about charity and its replacement and the $1 billion we're spending on that, and who's going to run it and who's going to govern it and who's going to get to work in there and where the address is 7.5 years hence. But I think for some of us, we just ignored that conversation and kept working in this space, knowing that eventually we would have a product that would be hard to not continue to buy. It wasn't just that we wanted to have primary care in the community or community health, it's that we wanted it to be good. Now, for us in the rest of the talk and going forward, when I talk about primary care in the city, I'm also speaking about outpatient mental health services. They are one and the same for us. They're in the same family. We work together from an advocacy and a financing standpoint. We do shared services together. They're integrated and overlapping in many ways. And so I want y'all to just try to keep that in your head. But the model that we were looking at was really this one in which patients had access to a medical home, dating back, really to the 40s in South Africa and importing all the way to the U.S. This idea that it wasn't just that you put primary care in the community, but it has to have some bells and whistles that make it accessible, that make it culturally competent, that allows it to coordinate care, that uses data to make decisions. There's some elements to it that are either clearly defined by NCQA and a formal accreditation checkbox, or by HRSA and others, Joint Commission. But really, the notion is with those right elements, you can improve care, you can improve patient experience, you can improve the physician and the provider experience across the board, you can reduce costs, and importantly for us in New Orleans, you can reduce health disparities. It's one of the really important ways that you can level the playing field for everybody. And so some of these early sites that the residents had staked out, this is at Covenant House, which is Covenant House, New York, I think is the original site. This is one of their branches. It's for at-risk youth. They had all evacuated. We broke into the building. We got some help from the police at the 1st District Police Station. I did break a couple of laws probably after Katrina, but it was emergency order, so it was fine. And the cops helped. And the reason we broke in was because it was a high ground and we could store stuff in there. And it became a multi-specialty clinic, and it was close enough to the French Quarter that there were a lot of people around. And we were able to not have to schlep supplies home overnight, and then had the HIV clinic and TB and others could show up here. Now, this sign, which is lovely, which we made, was the first sort of place that we began, and then we moved into a back building, this one here, went from that sort of street care model of literally giving out vaccines from an ice chest to turning it into an NCQA recognized Tier 3, top tier patient-centered medical home that could accommodate not just medical care, but has an entire mental health service line, that has a legal aid clinic, that has social services, that has travel aid, that has job training, that has outreach workers, that participates in conversations and education with community partners like the housing development nearby. Really overnight blossomed into a community resource, long before even much of the community was back. Now, the reason that we were able to do this is because we were not encumbered by the typical rules that come with financing of healthcare. So all this was paid for with philanthropy and with volunteerism. And as a result, what grew in the wild is the medical home, this idea of team-based care and accessibility, a very different model than I had ever managed or practiced in my career. And it really grew very organically, which should reassure us about the kind of model that we're aspiring to. It's what works well, and it's what patients really love. We actually now have a new building. This is the rendering, but it's open and been open for 9 months now. This was the original Ruth's Chris restaurant, which we got them to give to us and renovated. And now it's we still have resident continuity clinic. The medical students have a clinic there on weekends. We still have all the same service lines I mentioned, but now have more space to do more education and outreach. But we are one of a number of sites that have cropped up around the city. There were some 25 organizations that leaned forward in some way or another in the 4-parish regional area to stand up care. This map just reflects the sites that are open more than 40 hours a week, that do comprehensive care to the entire family. There are another series of school-based health centers, mobile units to some degree still, that are providing access points. We have over 100 in the community that are providing access points and serve about 20% of the New Orleans population in a given year. We are touching about 85% of the uninsured adults. We are still outreaching to try to find others to get them enrolled in the clinics. But at some point, we had as many as 400,000 people come through the doors in the course of the first 3 years of the clinics, I should say. We've had a couple of external assessments. This one's from the Commonwealth Fund. They surveyed 1,500 patients to see what their experience was like. They found that the patients that we were taking care of in that clinic were more likely to be persons of color, be uninsured, be low income, and report poor or fair health. Why do I tell you this? It's a source of great pride to me and others that the system that we built after Katrina was meant to include the sickest of the sick and the poorest of the poor and not exclude. The easy thing to do would be to try to push people out so your numbers would look better and people would return and it would be easier to take care of them. But these clinics really embrace the notion that the people who used to go to the emergency room at Charity were the folks that we really wanted to reach. And in particular, we wanted to be able to reach the working poor who needed evening hours and weekend clinics. They had a great experience. They reported the higher quality of care and that they were able to afford the care they had. There's a whole set of other indicators in this report that they did. The Kaiser Family Foundation's done another external evaluation, and Diane Rittenhouse at San Francisco. So we know some things about the experience of patients and doctors. I'll tell you also that for this 3-year window from the funding that we received from the federal government, from y'all to support this effort, the $100 million for 3 years, we had an additional opportunity to provide loan repayment for physicians, nurses, social workers, psychologists to staff the clinics. So it's one thing to have a bunch of volunteers come help and some residents, but you really need to have workforce. And when you crop up an entirely new infrastructure in the span of a couple of years, it's a stretch to make sure you have enough providers to take care of the community. And if you're doing team-based care, then you need people who are trained as community health workers and IT specialists and front desk workers. It's a whole new workforce that we have developed in our city and done that in a very deliberative policy way. We built some other things. As part of our blueprint, we did call for the entire system to be reframed and rebuilt. We have not made as much progress in some of the areas of hospital and financing, and I may or may not talk about it at the end, but I'd love to take some questions if you're interested. I just think it's really, considering all the work we've done in community health and in trying to change the framework of thinking that it's not all about the hospitals. We're still spending $2 billion on building a new VA and a new public hospital, which is soon to be private, as well as a hospital I'm building in New Orleans East for that community that has none. We are experiencing for the first time this year managed care in Louisiana. Does that make y'all laugh? And it has been such a disruptive technology, but it's really been important for providers to have to learn how to do that, not just for physical, but also for behavioral health. And now we are experiencing, on top of all that, a lot of hospital consolidation in the marketplace. So it's a very immature marketplace financially, and we're accelerating through a lot of things that you guys went through even in the 90s, just to try to make it a lot more stable and get ready for the Affordable Care Act, which probably won't come to Louisiana, but that's another story. We are, in addition to doing a lot of work in community health and access and shifting that away from hospitals but to other sites and neighborhoods, also been doing a great deal of work in health information technology. This was partially predicated on things like this that I saw after the storm. This is a really inefficient way to try to locate your patients at high risk, is to spray paint something on the outside of your building with a phone number for them to call, but it is the truth. What we have done very deliberately is to work on implementing electronic health records at the point of care. Easy to do when you either had no clinics to start with and you're brand new, and so there's no legacy system, or your entire legacy system became blocks of paper that were indecipherable, and so you had to reshift them. We had a little bit of data around, but really not very robust. The providers that I showed in the community health network, now 85% of them are using electronic health records, and soon to be everyone. The margins are really the mental health providers who were starting to implement a system, and when managed behavioral health came in, they recommended a different system, so they're in a new shift. We implemented a state health information exchange now a year ago, a little over a year ago, that is statewide and connecting hospitals so that if you are displaced, your data goes with you, or if you just choose to go to another community, your information goes and you're not having to use the old-fashioned information exchange, the fax machine. And we have a locally Crescent City Beacon Community Grant, which is a local health information exchange that connects the clinics to the local hospitals, so it's more vertically integrated versus the statewide one, which is more horizontally integrated with the big systems. What that means, in addition, is that all the clinics have had to work together in the last couple of years on defining who their patients are, so attribution work, and deciding how we are going to define diabetes and heart disease. And that sounds really easy, but any of y'all who have ever tried to do that know how ridiculously challenging that is. Even at auction or a big system, every department had their own way of defining diabetes and heart disease and their own set of quality indicators, even in one system. So everybody's kind of come together in the community, decided how to define it, decided what we're going to shoot for, and I'll show you a little bit later some of the progress that we're making in that area. It's been a big, important cultural change. It's kind of like students don't know what a Palm Pilot. Who knows what a Palm Pilot is? Right? So like you had a Palm Pilot, and that was great, but imagine the difference between that and having an iPhone is like pretty dramatic, and that's sort of the quantum leap we've made in the last few years, that it's not just this thing on your desk, it's a way that we can move the community and try to improve the public's health. We're about to execute on something called Medicator, which is a system that is an eligibility enrollment system, not just for Medicaid, but for a host of programs, whatever you put in the back end. And we are stealing this from Austin, Texas, where they have the same information exchange. It's like a plug-and-play sort of. And so whether you're getting enrolled in camp for the recreation department, or the WIC program, or Head Start, or a clinic, or a feeding program through Council on Aging, we can do a few questions and learn if you're eligible for other things. So we have about 2,000 elderly in our community that go to bed hungry every night because they don't know they're eligible for SNAP. So we want to find them, and honestly, in the clinics and other places, they're not thinking about asking that, but there's a lot of cross-match with the system. And for me as health commissioner, I'm going to start learning not just about who's in the health care system, but who's in the social services system, and be able to track and monitor, because as it stands, I don't have any idea. All right, so healthcare, great. We did a lot of work in the area. We are replacing some of our lost facilities and figuring out the best way to run and finance them still. And we built a lot of really great primary care that people are using and continuing to use. I told the students earlier that we still haven't convinced the state of Louisiana to spend a nickel on primary care in that network. We've still been relying upon federal dollars largely, but we are going to continue that fight, and hopefully the accumulating data we have will convince them that they should invest in primary care, not just hospital buildings. On the other hand, all that great infrastructure and cooperation in the healthcare sector is not going to do a lot to improve the public's health, right? Because only 20% of people's health outcomes is the healthcare system. So it could be the best on the planet. It could be Geisinger for everybody in Louisiana, no offense. We still wouldn't move up on the health rankings. Right? America's health rankings is much more than just healthcare quality and even coverage. It's about behaviors like smoking and eating healthy foods and exercise. It's about poverty. It's about educational attainment. It's about teen pregnancy. It's about public safety. And so to that end, sort of on the outside, all of us who had been working in the healthcare sector and making progress in spite of the government, without the government's help, whether that was local or state, we did have federal government help, and sometimes we had state government help. But really what it felt like was that we had cleaned up the neighborhood after Katrina, but we had one really blighted house, and that was the health department. And so we wanted to fix it. And when the new mayor came into office in May of 2010, he asked the community through a very open process, to give him input about what he should do in his administration. He had several hundred people participate in his transition process. I co-chaired his health care transition team. It was called Health Care at the time. And we made a set of recommendations around improving the health department so it could be a convener of stature, so it could do the work of public health as opposed to what it was trying to do, which was compete with the private sector very poorly, but undercut it on price in providing primary care and dental and other services. And amongst a few other things, but including thinking about the public's health more broadly. I'm going to toot my boss's horn for a second, because you don't often get to work for a politician like this. I don't think I'll ever, he might be the only one in the country. When we were speaking about what he wanted to accomplish with the transition team, we were talking about the community health stuff and the hospitals that were being built, the big ticket items. And after we finished that conversation, he said, that's all great, but those are better mousetraps. Let's talk about how we're going to improve the public's health. What about the education system and the criminal justice system? And he really understands intuitively the social determinants, and that's a very special place to get to work, and I think it's given a lot of energy behind what people like Tom Farley and others wanted to do years ago. So I went on leave from the university and went over to transform the health department. I was supposed to be gone a year. I'm still there, so it's apparently been a lot of fun. and we've made a lot of progress. I guess if I wanted to share, one of the top line things I want to share with you guys is what I have learned going on the other side is that public health is broken, and it is broken for things it did to itself over the course of generations, and it is going to have a hard time repairing unless it has a really cataclysmic shift in the way that we shifted, for example, healthcare in our city. It's very underfunded relative to healthcare. Healthcare gets about 97% of the funds, public health about 3% of the funds, even though there's an opportunity for public health to improve health about 80%, so it's a real mismatch. There is a very programmatic focus in public health, that it is taking care of marginalized populations and preset programs and not really innovating and not quite able to think outside of its own sector. So there is a need to retrain the workforce. There's a need to adjust the curriculum. There's a need to be more performance-focused and outcome-focused as opposed to process-focused. This is not just a New Orleans-specific issue. As I've learned, it's a national issue. It's a really exciting place to be because it is hurtling towards change in a really exciting way to rethink what public health should be and the way we can influence the health of communities. But it also is going to feel uncomfortable in some ways until we sort out the right language and structure. This is one of our public health nurses, but one of the old pictures that we have from New Orleans. We found an old book, not the kind of thing that we really do anymore, weigh babies, that happens in pediatric medical homes. But it was the kind of literally jobs that we still had on our budget through civil service was public health nurses. What is public health supposed to do? It's actually a set of core indicators, but boiled down to 3. They're supposed to assess need and capacity to assure that people are getting it in some equitable fashion, and then to drive policy to make people healthy. It's a really simple way to think about your life every day. What's sort of fun about it is you actually have like laws and an opportunity to do things in a way that you don't particularly in the private sector, but there's also comes with that quite a lot of responsibility. Our health department had no infrastructure to do any of this. We were trying to run clinics and programs, and we were completely ignoring big public health issues. So we have spent the last few years stabilizing the environment. That was a very fun experience, and I'd be happy to talk to anyone afterwards about it, but it was also a very terrifying experience to know how broken our health department was. I'll just tell you this. There was an external consultant who came and did an assessment at the mayor's request of our city government before he began his term to tell us how we were doing and what we needed to do to improve to make government work. And that consultant said that in his 25 years of work, he'd never seen a city government so dysfunctional and broken as the city of New Orleans was. And this was not a Katrina effect, I'll tell you, because as I got digging into the health department, I found decades of problems and mismanagement, quite frankly. A complete, more than anything, lack of management. No playbook. Nobody with an understanding of why they were getting up and coming to work every day. And in fact, no expectations that people were going to get up and come to work every day. There was no HR expectation. A lot of depressed staff who just wanted some direction, and a real need to fix the physical environment, but also deal with inventory and budgets and HR. So we spent the first year doing a lot of environment stabilization. And I want to tell you, like, bad clinics. I'm going to tell you, no EKG machine in the adult medicine clinic kind of stuff. Like, just really scary to me that a modern American city was like that. We began to transform, set expectations, and we used as our roadmap a public health accreditation process that reminds me a lot of the medical home accreditation process. Not quite as icky as Joint Commission, but really more about community quality improvement and setting a strategic framework and a community health assessment plan that you do with community, and then an improvement plan you do with community about where you want to go. We are now, we've actually now applied for accreditation and are expecting a site visit this summer with the goal of having been the worst in the country to being best in class in the country in a short period of time, so we can actually really do the broader health population work that we ought to be doing. And frankly, we've been able to adjust some of that and raise some dollars to be able to focus on that idea of health and everything, as well as population level management. Because when we get there, then we can start to really think about yes, we do have core public health function, but there's also then this need to address the social determinants, and they arise every day, all the time. And in fact, in most of what I do, I'm thinking more about social determinants than traditional communicable disease public health. Now, granted, the state does a lot of that function for me, and so they relieve me of the burden, but the truth is that the scourges of modern society, the things that are killing us, the things that are shortening the lifespan of children are not really syphilis anymore, thank goodness. It's really obesity and violence and a host of other public health scourges that are much more complex, but that I think public health is well equipped to deal with. It's an interesting place to take on that task because you're rebuilding the social determinants, and we have been for a few years, and Tom Farley saw that very clearly a few years ago. But for better or worse, because the 4 years after Katrina, we had an administration that was not attentive to rebuilding or unable to get over their inertia. We have, in the last couple of years, 3 now, been incredibly busy rebuilding, using place-based development strategies, incorporating bike lanes, doubling the budget for parks and playgrounds and after-school programs for kids, working very intensively with the school system about food policy and about PE policy and about trauma and resiliency. So really, as a government pushing out, but also the community has been incredibly civically engaged and active. And before I got into government, I was on the outside thinking government was pretty broken, which it was. And so the community, I have to tell you, owns this. We push it, and we can drive a lot of it, but they have a great feeling for how they're going to put these streets and communities back together. So how are we doing on improving the public's health? We have the framework of structure, process, outcome is important for me to share with you all. So we jumped off the cliff and built our wings on the way down. And I still find I'm doing that a lot. It makes it hard to be, it's not like we wrote a grant and planned out data collection and study visits. It's just, we just went. But we went really quickly to building the right structure, because the lesson was, if in the vacuum we could replace what we had, paper records, emergency rooms as the principal source of care, financing that drove people to hospitals, a lack of understanding about quality, a lack of communication across sectors, then we would be in a position where we could begin to impact process and outcome. I'll give you an example, though, where very deliberate policy action, we've already seen the results, and that is in primary care. I told you that we were some of the lowest in the country prior to Katrina because of community decision to attract primary care, because we invested money in loan repayment programs for recruitment and retention. We are now in the top 10% nationally of primary care per capita, which still stuns the community at home when I tell them that, but it is the truth. Now, whether people are connected entirely, et cetera, that's still an effort that we are working on literally every day. But we have seen the success of focusing our efforts and some financial investment, changing the kinds of places people get to work, changing the way we train the medical students to help them get interested and attracted to that kind of work. Because we have covered people through a special waiver program called NOKI for primary care, we've been able to drop the uninsurance rate from 21% to 12%. Now, that's just for primary care, but we know now that if we could get coverage expansion in 2014, I'll automatically have those folks enrolled. And that means that we'll have halved our uninsurance rate in the community, which right there does a great deal to improve health outcomes. We're still enrolling people, and I hope that we can get that number even lower and convince the governor to expand coverage. We've also been working on making sure that there's a system to greet those people appropriately. She mentioned at the outset that we're really proud that we've been recognized nationally, including by Secretary Sebelius, who has invested in us through this waiver program, the quickest turnaround in history of a waiver. It's actually the first one Louisiana ever had to figure out how to use DISH money to pay for primary care. So lots of cultural shifting and national recognition. Definitely learned that we have a long way to go to make this completely institutionalized, but the clinics are getting really smart and about their business savvy and consolidation and moving towards FQHC status so that there's opportunities for more revenue stream. That's my boss on the right, by the way, and that's the Secretary of Health for the state of Louisiana. Bruce Greenstein in the center. It was about his first week on the job, but he really made sure that we got this to happen too. Now that we have the beacon data, so electronic health records, great, collect it, put it all into a centralized database, begin to do some analytics and understand how well we're doing taking care of the patients. So we're still sort of tracking who all is participating in that process. We're able to track when people go to the emergency room. This is sort of life-changing, because if you are uninsured in this country, you're invisible. Right? We don't actually know the quality of care you get. We don't know how healthy or unhealthy you are. We don't know what it costs to take care of you. We just guess because there's no number tracking you. Now that we've got people enrolled and we can begin to work with the hospitals to track, we're going to get a sense of whether we're able, through our efforts in primary care, to reduce cost because of emergency room visits and hospitalization. We've also been looking at the quality outcomes that I mentioned, and we're seeing that we're making some progress in some core areas. This is really just about a year into the work, and so we're expecting that we're going to make continued progress. This program, the Crescent City Beacon Community, has been written up now a couple of times recently for this for the work around collaboration and cooperation among primary care clinics, and is being recognized at HIMSS in a couple of ways. The information technology meeting that's coming up. Let's see, I talked about the health department, social determinants of health. This is our this is what I got to do last week, which was go to the Robert Wood Johnson Foundation and have our city, small c, recognized, meaning not the city government, but the city, recognized with the Robert Wood Johnson Roadmaps to Health Prize. So we were one of 6 cities selected in the country out of 160 who applied. Demonstrating that we are laying down all the right foundation to be one of the healthiest cities in the country. So attentive to the social determinants, thinking about access to primary care, thinking about equity, and got to lead a delegation of folks from the city to be recognized. It is so unusual for us to be on a good list that we're still a little bit glowing from the whole thing, and we appreciated that very much. And that's sort of all the good fun stuff. But quite frankly, I think one of the really interesting areas of work, in addition to thinking outside of traditional public health, is looking back on healthcare. And I wanted to end just by saying a few words about that. I mentioned earlier that public health is kind of broken and marginalized and poor. So it's like general medicine, right? So I'm just teasing a little bit. And that's a little plug for my friends in general medicine. But it has a lot of opportunity to deal with complexity and make significant improvements. But it's going to need a partner, and that's where I think the healthcare sector is really critical. Healthcare is got a lot of data and resources and a bully pulpit in a way that public health really doesn't. It's the respected portion of the partnership, more so than public health in most of the country. And so we are spending time also thinking about how we work collaboratively. The Beacon grant that I mentioned is one of those areas of interface. We are working with the feds and with that local effort to use that data as a way for me to proactively know who the vulnerable members of our community are in the event of disaster, both for preparedness and for response and for recovery. Y'all remember in Sandy that their power went out for a long time and people were going door to door. I think y'all probably did, trying to find elderly folks and people who were had ambulatory challenge, et cetera, to find them and get them to safety. We had the same thing during Isaac, which just happened to us in August. And though I have a registry of medical special needs people, it's passive. You have to call me, so you have to speak English, you have to have a phone, you have to not be demented. Like, there's a whole series of things that are required in order for you to be on my list. And what I want to know is everybody. I want to know if you're on a home oxygen. I want to know what your DME status is. And Medicare knows a lot of that, and so does Medicaid. And then for the uninsured, we know that from the Beacon. So putting all that together, we can map out with people's permission where they live. So I'm not knocking on doors like I did after Isaac and hoping I'm going to knock on the right door and find the right person and they're going to be willing to come. So we have some really exciting work that's a nice collaborative process using claims data. And remember I mentioned this Medicator, which enrolls people through social services programs. I'm going to then be able to have a layer that's not just you're using the health system, but beyond that of everyone in the community and knowing who's most vulnerable. Another area of example is violence reduction. I didn't speak too much about it, but we have a set of efforts that we work on that are public health priorities. And murder reduction is the most challenging one we have, and the number one priority, honestly. The community mentions it over and over again. We have a murder rate that's about 8 times the national average, and has been for 30 years. We have young black men killing young black men, 241 of them on average dying every year. And it is a really complex social issue, and there's lots of places to intervene. It's a well understood that has some elements of that public health can address easily. Though there are a lot of ways we're tackling that as a community. I'll just, as an example, tell you about our hospital ceasefire program. So this is a way that the healthcare system and public health and the government are cooperating to identify people at that teachable moment when they've been shot and or a family member's been shot in their trauma case, to intervene and get in there and try to stop the shooting by very directed counseling and conversation so that there's not retaliation subsequently. There are, and we have piloted it in our Level 1 Trauma Center at the public hospital. It's gone really well. It's been well received. And so we're now about to expand it so that there's a more robust effort, plus we can get out in community. So just a couple of examples of ways that we're working together on the ground in New Orleans. I could give you many more, but I do want y'all to walk away with the idea that to improve the public's health, it's an everybody in game. Everybody has a role. And I went over to public health to understand the social determinants and how public health could influence. But looking back now, it's really clear to me that medical system has a huge role to play. And whether you're standing in the role of public health or just working with it, it's such a great opportunity for this country to be healthy again. And I encourage the leadership of the university to continue what you're doing and giving students exposure to that, so at least they have an appreciation of people's context, and then thinking through ways that you can more closely weave together with your own local public health system, state, and otherwise. Thank you all.